Principles of biopsy. What are the goals of our intended goals and learning objectives of this talk? We want to know about the principles of biopsy and about types and advantages and disadvantages and the technique and common sites that we should take biopsy from. So our questions for today: why all the fuss? Why we are giving all that importance for biopsy, and why we are taking care of biopsy, and who should perform the biopsy, which method of biopsy we should follow or we should use, what are the general principles that should be obeyed in order to come out with good outcomes, who is to send your biopsy to. Do you want to send your biopsy to any lab, or there is a special criteria that should be available in that lab? Okay, so why is it important? Why is it important? And why we care of taking that biopsy? If you look for this 11-year-old girl, she is presented with painful swelling, and unfortunately, in somewhere out of the Khartoum, she was receiving a treatment of multiple drilling. The surgeon assumed that she has chronic osteomyelitis. By the way, chronic osteomyelitis may sometimes mimic Ewing sarcoma, because patients will present with painful swelling and fever. So it could be like an infection. So that patient, unfortunately, just the surgeon, without any biopsy, he assumed that this is a case of chronic osteomyelitis, and he did multiple drilling for that chronic osteomyelitis, and unfortunately he opens a new pathways for the tumor to go in, and the tumor invaded with the easiest way that new compartments. And unfortunately, after a while, they discovered this is a very huge tumor, and after taking biopsy was proved to be an Ewing sarcoma. So biopsy is very essential, because unfortunately this patient lose her lower limb. This articulation was done for that patient with 11-year-old. So it is a catastrophe. And this is a pathological fracture. Unfortunately, there is a wrong concept that any pathological fracture you could go and put a nail. And this is not the ideal treatment, because if you just go and do that, sometimes that type of looking innocent lesion could, after you take a biopsy, it turns out as a malignant bone sarcoma, primary malignant bone sarcoma. And if you go and put your nail, you are going to do a reaming. So if you did that, this is mean that you further push the tumor cell into the distal part of the femur, and by the reaming you bring it more to the proximal part of the femur. So you will be run out of option of limb salvage if you want to do a limb salvage in such a case, because all the compartment of the femur already contaminated. You need to do something very expensive like total femur replacement, or this patient is going to end even if he cannot do that, or contamination is beyond salvage procedure, he is going to end with disarticulation or sometimes with modified hemopulvectomy. So if just you took a biopsy and you wait for a while, you put a patient in posterior slab and wait for 5-7 days, you are waiting for just to know solidly what is the diagnosis, because this innocent, just radiolucent area could be low-grade osteosarcoma. This is primary bone tumor. Primary bone tumor, we didn't do for them a nail. The principle is to do a wide resection. A wide resection is taking whole the tumor without opening the tumor, as implant with normal soft tissue in all directions. So whether it is soft tissue with normal tissues actually in all directions, whether it is soft tissue like muscles or whether it is bone, you are going to take it as implant without seeing the tumor, without opening the tumor. So that a different principles, different from that principles of dealing with metastatic bone tumor. Yes, if it is a metastatic bone tumor, then nail, if you did a nail, no one is going to blame you, because if you did a nail, because here you are not fetching, you are not looking for radical treatment, you are not looking for curing of the disease. You are just doing something palliative to improve the lifestyle, to let patient walk out of bed and dependent on himself or herself. So the management could be something good if it is just metastatic disease. And we know that there are 5 areas could give mets, from CA breast, CA thyroid, CA lung, and renal, CA or prostates. So this should be taken into consideration, and it's very important, because here in this case this is turned out to be a giant cell tumor. Unfortunately, this patient underwent nailing, and that nail looks very nice post-operatively, because they didn't do any biopsy. They feared the tumor distally and proximally, and after a while become with that soft tissue swelling and loosening in the femur, and this was the swelling. Unfortunately, this patient already lost actually her limb, and she lose her chance for doing a salvage procedure, because she end up with this articulation. So biopsy is very important, and it tend to keep you out of trouble. Just do a biopsy before you go further and do something maybe you will regret after a while. And biopsy is very important, because you can differentiate whether it is horse or zebra. So horse and zebra looks like, but if you took a biopsy, you can differentiate also between infection, whether it is infection like chronic smyelitis or tumor like Ewing sarcoma. You don't need to assume. You have to go on solid background, on solid basis. So you can differentiate by biopsy whether you can say solidly this is infection. So you can do whatever you want to do. But if it is proved as Ewing sarcoma, then you need to do something according to the guidelines. And you could differentiate between horses and zebra, primary or metastatic, simple fracture or pathological fracture. So biopsy will help us to have a solid diagnosis. But biopsies has a consequences. If you took inadequate biopsy, this means if you sent non-representative sample to the histopathologist, so this could delay the main treatment, because this means that you need to take another biopsy and send it back, and will take about 2 weeks or something like this, and maybe it will give a wrong diagnosis, or will end up with adverse prognosis, because multiple attempts of biopsies could make the bone very weak and could ends up with pathologic fracture, or contamination of tissues of by the tumor, because improper placement of biopsy. This means that you go with normal compartment through normal compartment in order to reach a tumor, and you take that tumor cells and bring it out through that normal compartment. So you are giving invitation for tumor to invade the normal compartment. So before you go for biopsy, you need to know all your investigation. You need to know knowledge about which compartments are involved and which are not involved. And here also you have to do biopsy with minimal cause of devitalization of the tissues and go away from major blood vessels in order to avoid hematoma, because hematoma and bleeding could be a potential for the tumor cell to be spread through it to another area by seeding of the tumor cells. And unfortunately, if you didn't take care for that principles, maybe you are going to let patient to go for amputation. You will not give chance for the patient for doing any salvage procedure. Patient will be run out of any possibility of doing something good, because he is going to do an amputation. Functionally, it is known that amputation is less than patient salvage procedures. So biopsy is critical. And what are the significance of biopsy and what are the indication for biopsy? Here are the significant. The significant is to confirm the clinical diagnosis and accurately classify the lesion, because we will have histological grades for that tumor, so we can diagnose and classify, because part of the classification, anything classification has two pillars: the anatomical extension and the grading, which we get it from biopsy. And what are the indication when biopsy will be indicated? Actually, it will be indicated in any questionable lesions and any malignant tumors and any aggressive benign tumors such as cancer tumor. You have to take a biopsy before you go in. Who is the qualified person to do the biopsy? Actually, this is a very important question, because you cannot dare to do a biopsy without knowledge of the investigation and the images. You have to go through the x-rays and the MRI and the other images, like MRI, you need to do to go for the contrast views, the coronal and axial and sagittal, in order to know which compartment exactly and to what extent the extension of the tumor intramedullary, and to know where the blood vessels, is it pushed anteriorly, posteriorly, where to go, which is the shortest tract to go and take biopsy without doing contamination to the normal compartments. So it is the surgeon that who is going to do the definitive surgery, or the team who is going to do the definitive surgery, which will be of good knowledge of the images of the planned incision for the definitive surgery, because you need to put your biopsy incision within the same tract that will be done for the future planned limb salvage procedure, because you want to take the biopsy tract with the definitive incision plan. Okay, because biopsy tract considered are potentially contaminated, and it could be a cause of recurrence of a tumor. So the one who is qualified is the one who has the knowledge of the clinical imaging and diagnostic, the pathology and treatment of the soft tissue tumor. Actually, we are not going to take biopsy by someone who doesn't know the principles, and we are not going to talk here about just single man. We are going about a team, the onco orthopedic team. They are the team already or going to do the definitive surgery. So we will assume that that team has the basic knowledge of the clinical imaging, diagnostics, and the pathology treatment of, and the pathology and the treatment of the bone and soft tissue tumor. Also, the one who is prepared and qualified to resect. So the one who is going to resect the tumor, doing the definitive surgery, has the capabilities to do that, is the most person who is qualified to do the biopsy, because he knows where to put his biopsy, in which site, and to decrease risks of biopsy. The decision regarding type of biopsy needs some experience, because you will build that decision after finishing all the images, and you will start to select the region of the lesion that has to be biopsied. And it depends on the anatomical approach and biopsy technique that you are going to use. So which method of biopsy you are going to use? Okay, you have some biopsies that could be done open, like incisional type of biopsy. And actually, we do an excisional biopsy in benign cases that we are completely deadly sure that is a benign tumor, like osteochondroma. We go and do excisional biopsy. We take all the bony and cartilage cap exostosis and send it for histopathology. This is, we call it open type of biopsy, and in the open type, actually it is excision, and we do it just when we are deadly sure, we are 100% sure that this is a benign bone tumor. Or if it is malignant bone tumor, you can do open incisional biopsy without taking all the tumor out, because it is a malignant. There is a suspicion that is malignant bone tumor, primary bone tumor. So just you take a sample, and later on, after you get a solid diagnosis from the lab, you can go and resect as wide resection. And there are another type of biopsies that could be done closely without opening the wide incision or long incision. And this has many types, like the core biopsies, which has two things: the true cut needle that we use it for the soft tissue tumor or prostate, like the urologists also they use it, or the Jamshidi needle that we use it to take a biopsy from the bone. And there is also the fine needle aspiration cytology. But fine needle aspiration cytology is not suitable for orthopedic. And this is because the fine needle aspiration needs homogeneous tissues. It is suitable for carcinoma rather than sarcomas, which has heterogeneity, different tissues in the tumor. So please don't do fine needle aspiration, and don't rely on what do you get from it as a diagnostic measure in bony sarcomas or soft tissue sarcomas. Fine needle aspiration definitely has an important limitation of stem from its inability to sample tissue matrix adequately and to show tumor structure. And here in bone sarcomas, we are running behind the tissue matrix. We want to know what type of matrix. Is it osteoid laid matrix like in osteosarcoma? So fine needle cannot give us more information about that issue. And fine needle aspiration is particularly useful in evaluating for soft tissue recurrence. Sometimes we use it for evaluation of soft tissue recurrence, and especially for lymph node metastasis. Otherwise, better to avoid. And scatter cells for microscopically study and highest incidence of false negative. It has the fine needle aspiration cytology has highest incidence of false negative. This means that the tumor will bring it for you that there is nothing and it is negative, but actually it is false. Sometimes there is something. And when positive, it is of low accuracy for specific histologic types and grades. So we just have the option of core biopsy. And the core biopsy, whether you take the Jamshidi needle and take a biopsy from bone, or you take the true cut needle biopsy and take a biopsy from soft tissue. Biopsy, this has become nowadays the biopsy modality of choice, and it shows that there is specificity and sensitivity of high rate, about more than 90 something in many of the recent studies, and has accurate in differentiating malignant bone tumors from the benign lesions. So bone biopsies using core needle biopsy should be performed sometimes under CT or fluoroscopy guidance, and multiple cores should be obtained. Actually, we will not be happy unless we took or take unless we take about 3 to 6 good cores of biopsy, because we don't want any problem of that tissue is inadequate, as some histopathologists could give a comment. He cannot reach the diagnosis because your tissue that you sent for him is inadequate or not representative. So we actually take 3 to 6 good cores from different sides of the tumor by the same incision, and this is because we want to sample all the tumor site, because especially in the large volume size tumor. If a soft tissue tumor is palpable and is remote for the neurovascular bundle, a biopsy can be performed in the clinic setting. Sometimes this option is done because we fear of infection will be always we are reluctant to do taking biopsy samples at outside the major main orthopedic theater, because we are fear of getting an infection. An infection is a very big problem in patients of sarcomas or tumors, because it will gonna to delay the main treatment, the chemotherapy. On the right of the presentation, you will find the Jamshidi needle, and on the left, this is the true cut needle. The true cut needle, we take a biopsy using it for soft tissue tumors, and on the right side, the Jamshidi for taking biopsy from bone. Here is Jamshidi needle that used in distal femur osteosarcoma. We took a biopsy. Look, it is just a puncture. There is no wide, long incision, just puncture. From that puncture, you can sample every side of the tumor, because you take different sides of the tumor as sample. You're going to take about 3 to 6 good cores, like in this picture, which is going to be obvious to you right now, like this. This is multiple cores, and it is a good sample. So what about the incisional biopsy? Actually, incisional biopsy, previously the pathologists considered that is gold standard because it gives a lot of abundant of tissue sample, and they are rely on for diagnosis. But nowadays they get more experience with the core needle biopsies. And in the past, they rely on that method for diagnosis because it provides materials for performing ancillary studies. They have abundant soft tissue. They can use immunohistochemistry, cytogenetic studies, and blah, blah, blah of the other studies they want to do. They have enough abundant tissue. It allows the pathologist to evaluate cellular morphologic features, and it allows the pathologist to evaluate the tissue architecture from different sides of the lesion. And open biopsy is performed when the pathologist or the pathology diagnosis either inconclusive or doesn't correlate with the clinical presentation and radiological finding. And biopsy of deep-seated or pelvic soft tissue tumors, actually we perform it under CT guidance because sometimes you cannot reach with your needle intraoperative, you cannot reach a deep sites inside the pelvis. So we prefer that deep side, inaccessible side to be done under the influence of the CT guidance in order to take the exact side of the tumor as biopsy. Excisional biopsy is done for just benign bone tumors, as we said previously. And actually, when you look for this view, that small puncture, you need to know this is a concept. It is not just biopsy. Does biopsy is just a small keyhole surgery? No, it is a concept. There is a lot of concept. There is big principles, a lot of principles actually you should follow for doing good biopsy. And it is a concept rather than just small puncture or keyhole surgery. So what are the factors that make the difference between a successful biopsy and a catastrophe one? What are the principles of biopsy? The principles of biopsy performed and at the conclusion of staging. Please do not rush for biopsy before you finish your investigation, because if you did a biopsy, then you send patient for MRI, that architecture will be changed by your biopsy. So please finish all the investigations, all the anatomical extension, whether there is distal metastasis, and if you did an MRI, you will find which compartment is involved, which compartment is preserved, what is the shortcut approach you can use it for that biopsy from that lesion. So please perform your biopsy after conclusion of the images. And this should be representative, that principle 2, because you need to take not from the center, avoid central necrotic part and central necrotic area. And sometimes we use the frozen section intraoperatively in order to judge about that biopsy. Is it representative, or that way of taking a biopsy from different sides are representative and can give good tissue for assessment, or whether that tissue is fully of necrotic tissue. So frozen section could be used to assure that biopsy is representative by taking some sample intraoperatively, just not to diagnose, but to say this is a representative sample with full with viable tumor cells and not fully with necrotic area. Because when the tumor tends to grow, and it grows, actually the sarcomas grows in centrifugal manner. means that it starts centrally and then goes outside, push the vessels and the soft tissue. So once the tumor grow up and become of large volume, the center, because will be derived from the blood supply, it will become necrotic. And if you take a biopsy from that center, that will not give an answer or diagnosis for the tumor. So please avoid the central necrotic area. Okay, and avoid area of Codman triangle, because Codman triangle means that there is some osteoid and there is could be interpreted wrongly as osteosarcoma. And what part of the lesion has to be biopsied? That is a very important question. Are you going to biopsy the soft tissue component just, or you are going to take part of the bone? And by the way, the soft tissue considered as representative as bone. And the second question, what is the safest anatomic route? In order to answer this question, you have to go through the all images. You have to go through the MRI, see which compartment is involved, what is the shortcut approach, how I can reach that, how I can avoid the major vessels. So you need to assess for your biopsy. The surgeon must be familiar with the technique of potential definitive procedure, and he should know where to put his biopsy in order and in view of the coming incision that is going to be made, in order to take that part or resect that part for the future limb salvage procedure, in order to take any tract which considered as potentially infected tract. The Kisra osseous component of the malignant bone tumor, like soft tissue, is as representative of tumor as is the bone component. So you can take from the soft tissue. It is not important just to say this, oh, this is soft tissue, I'm not going to take from it. No, you can take from the soft tissue, because the soft tissue is considered as representative as a bony component. And if you look for those pictures, the biopsy tract must be the shortest way to the lesion. Look here at the proximal tibia on the left side, and the shortest lesion, the shortest tract on the medial side, biopsy taken from the subcutaneous tissue immediately directing to the bone. So that is the shortest tract. You are not allowed to go from the long tract, because if you do that, maybe you are going to contaminate that tract. So you do it for the short, the passage of the tumor cells coming with the biopsy should be the shortest tract. And on the right side, you will find the tumor in distal femur and the proximal femur, and also it gives you the shortest tract. So you need to go for images and know which tract, which is the shortest tract, before you go and do your biopsy. And even you need to put and position the biopsy over the incision, the future incision for the wide resection, because you need to take that tract within the incision. You are going to use it for the wide resection you are planning to do in the future. So like this picture on the left, there is around the knee, there is the biopsy tract, and fortunately the surgeon put it in view of his future planning for the definitive surgery. So when he did his definitive surgery, he took that part of the tract of the biopsy within the main incision of the surgery that done for limb salvage procedure. And you must not violate more than one compartment. If the tumor is invading the anterior compartment, there is it is not sound to go from posterior compartment, not sound to violate another compartment. You have to preserve the normal compartment as it is. So avoid extra compartmental and joint space, and avoid avoid peridural space. Avoid intermuscular plane. You don't go intermuscular between the muscle groups. No, you go directly through the muscle lesion, muscle incision. You go intramuscular rather than intermuscular planes. And you use the smallest longitudinal incision that is compatible with obtaining an adequate sample or specimen. You don't do transverse one because skin is very precious, just longitudinal. Don't adopt any transverse incision for biopsy. Use knife or curette to avoid crushing or distorting the specimen texture. And this is actually, by the way, is very important because sometimes some surgeons took nice biopsy, but they destroy the architecture before it goes to the lab by taking that biopsy with sharp instruments like tissue forceps, like other sharp instruments. So you just take that biopsy and bring it with the widest part of the Jamshidi needle, and you just push it by curette or knife without using something crushing, because what you do here will be there under the microscope is something major. You will think it is just not a problem. No, it's a very big problem for the pathologist, because if you destroy that matrix, he cannot reach the diagnosis. So please be gentle when you take that biopsy. And the shape after you did biopsy, if you do an osteotomy inside the bone, please you should know that how to decrease the stress riser, because if you make the edges of the bone very sharp, this will increase the stresses that will act and influence the bone, and this will lead to pathological fracture. So please make your ends, your corners, made it more rounded rather than sharp one, because this could be also a problem that could lead in the near future for pathological fracture. And if you take a biopsy and making more than 1 to 2/3 of the bone cavity, better you put a block of bone cement, because again, this could be a risk for pathological fracture. As general rule, please culture what you biopsy and biopsy what you culture, and do meticulous hemostasis, especially in the open biopsies. And if you use in open biopsy tourniquet, the limb shouldn't be exsanguated. Don't exsanguate the limb. Don't ما تحلب الرجل. Just اربط التورنيكيت بتاعك without any exsanguation. The tourniquet must be removed before wound closure. And the drain should be in proximity to the wound and same line of the incision. And please put it on B position, avoid C and A position, because if there is a recurrence, you want to take the B, which is nearest to the incision line, and just avoid other away drains that could be put in A or C. And avoid the contaminated problematic skin. Don't take from that getting problematic skin. Go away from it. And avoid the vascular bundle. Go lateral to the cephalic vein if you take a biopsy from the shoulder. And incision of biopsy do not undermine the subcutaneous fat, because this will feed some tumor cell under the skin, and this is could be risk of recurrence, because you put tumor cells in a new area. Do not use excessive force or retractors on retractors. Be gentle, because you don't want to further contamination with tumor cells. Do not irrigate the wound, and close pseudocapsule after biopsy taken. Do not infiltrate with subcutaneous local anesthesia after incision, because this will be also cause of seeding of tumor cells. And when you do your incision, please do meticulous repair for the skin. Put your sutures nearby in order to end with a nice picture of your incision, and avoid to cross the joint in order to avoid the contraction and avoid that ugly scars like in this patient. The biopsy has many complications, like iatrogenic injury to the blood vessels or nerves, complicated wound healing, wound infection, tumor cell contamination along the biopsy tract, subsequent local recurrence. To whom you should send your biopsy? Actually, better you send your biopsy to one lab that that they know how to deal with the tumor of bone sarcomas or soft tissue tumor, because that part is very difficult part of the pathology, histopathology. This needs someone with good experience, and you have to send it to a lab that you could communicate with him, with the pathologist. It is easy to communicate with him because it is a multidisciplinary team and multidisciplinary discussion. And you have to send a good request form for the biopsy. You should include the clinical data and imaging finding, as diagnosis is based on combination of clinical and imaging and histological data. Include surgeon, your name actually, and your contacts in order if you want, if the pathologist want to reach you, it will be easy for him. And please don't send the biopsy for a lab without following what's happening for that biopsy. Follow up and call from time to time in order to know what happened with that biopsy. Finally, taking home message, biopsy is not just keyhole surgery. It is a concept which has many principles, and it is a crucial step in the diagnosis. And don't rush for doing any pathological fracture without a biopsy. If you fail to plan for biopsy, that means you are planning for failure. That means you are giving an invitation card for complications. Thank you for listening, and thank you. We can hear about if any question. Thank you.